Good afternoon, our dear friends. Today I'm glad to present you our next lecture in Propaedeutics cycle. And now we continue learning signs and symptoms of cardiovascular system disease. You remember that previous lecture was about general investigation, general evaluation of patients with cardiovascular system diseases. And today I am going to discuss with you one specific syndrome. It is a very often and very important problem in all countries for today. It is syndrome of arterial hypertension. Plan of today's lecture. We will give definition of arterial hypertension. We will discuss classification, causes, clinical picture, and diagnosis of arterial hypertension. Okay, what about definition? Hypertension, also known as high blood pressure of arterial hypertension, is a chronic medical condition which the blood pressure in arteries is elevated. Hypertension is having a blood pressure higher than 139 over 89 or more than 140 or 90 millimeters hydrogram for most adults. Different criteria apply to children. Types of arterial hypertension. It can be primary or essential hypertension. It is 90% of all cases of hypertension, defined as high blood pressure with no obvious underlying cause. And secondary hypertension. It is nearly just 10% of all hypertensive patients, defined as high blood pressure due to an identifiable cause, such as chronic kidney disease, narrowing of aorta of kidney arteries, endocrine disorders such as excess aldosterone, cortisol, catecholamines, overproduction, etc. Classification of blood pressure for adults. For modern guidelines, now we ruled out by European guidelines. American guidelines, they are a little bit different. The level of normal a little bit lower for American guidelines, but we in Ukraine we more use European guidelines, and here you see this classification. Normal blood pressure, it is from 90 to 118, it is for systolic, and diastolic from 60 to 79. High normal blood pressure or pre-hypertension, it is systolic blood pressure from 120 to 139 and diastolic blood pressure from 80 to 89. And what is higher? It is hypertension. We can divide it in stages. Stage 1 hypertension, it is systolic blood pressure from 140 to 159 and diastolic from 90 to 99. Stage 2 hypertension. For systolic, it is 160 and 279 and diastolic from 100 to 109. And stage 3 hypertension or hypertensive emergency or hypertensive crisis. It is systolic blood pressure higher than 180 and diastolic blood pressure higher than 110. And we have one more specific type of hypertension. We name it isolated systolic hypertension. We can put this diagnosis when systolic blood pressure is more than 140, but diastolic blood pressure less than 90. Hypertension results from a complex interaction of genes and environmental factors. Numerous common genetic variants with small effects on blood pressure have been identified, as well as some rare genetic variants with large effects on blood pressure. But the genetic basis of hypertension is still poorly understood. And secondary hypertension, you remember that 10% of cases it is secondary, it when we can find some exact cause of this hypertension. What it can be? Most often it is kidney disease, It can be Cushing syndrome, it can be hyperthyroidism or hypothyroidism, it can be acromegaly, Conn's syndrome, hyperaldosteronism, it is hyperparathyroidism, pheochromocytoma, obesity, sleep apnea, pregnancy, it can be drug-induced, etc., and other more rare causes. Hypertensinogenic risk factors. What risk factors can lead to hypertension, to such an orphan problem? It is age, race, sex, family history, obesity, sedentary lifestyle, insulin resistance, using tobacco, high alcohol intake, high salt intake, stress, dyslipidemia, low potassium intake, low calcium intake, too little vitamin D in diet, and certain chronic disorders. Yes, you see such an often risk factors. It is the basis of explanation why for today hypertension it is one of the widest disorders involved at all, and it is one of the most important killers of people in this world. Okay, for evaluation hypertension we use SCORE system. SCORE, or Systematic Coronary Risk Evaluation, is cardiovascular disease risk assessment system initiated by European Society of Cardiology. SCORE is based on risk factors. It is gender, age, smoking, systolic blood pressure, and total cholesterol. Height score, it is a little bit other scale, is the interactive version of SCORE. The threshold for high risk based on fatal cardiovascular events is defined as higher than 5%, instead of the previous higher than 20%, using a composite coronary endpoint. Okay, how it look like? Here you see the table with stratification of total cardiovascular risk. It is how we determine the cardiovascular risk for patient with hypertension. It is very important classification even in your diagnosis, in your case histories. It will be a point with the score level of score for general cardiovascular risk. Yes, and it dependent on presence of risk factor. You see in first column, yes, no other risk factors, 1, 2 risk factor, 3 or more, or some severe risk factors like kidney problems, stage 3 diabetes, etc. And next it is risk with symptomatic cardiovascular, for example, patient with present coronary artery disease with heart failure, or chronic kidney disease 4 stage and higher, or diabetes with organ damage. And according to level presence of these risk factors and concomitant disease, and by level of blood pressure we can check the risk for each individual patient. Yes, it can be low risk, low to moderate, moderate risk, moderate to high, high risk, high to very high, and very high risk. Pathophysiology of hypertension. I hope on pathophysiology you learn on all of it. It is a very multifactorial process, and shortly let's repeat. Yes, key factors of pathophysiology. It is abnormal sodium transport. It is increased sympathetic nervous activity. It is increased renin-angiotensin-aldosterone system activity. It is vasodilator deficiency. Signs and symptoms of hypertension. Most people with high blood pressure have no signs or symptoms even if blood pressure readings reach dangerously high levels. A few people with high blood pressure may have headaches, shortness of breath, or nosebleeds, but there is signs and symptoms are not specific and usually don't occur until high blood pressure has reached a severe or life-threatening stage. Main complications. Hypertension danger not by exactly symptoms, but it is very danger by complications. And what complications can lead to very severe emergencies, to some another chronic and acute disorders, and even for death. First of all, it is hypertensive heart disease. It is remodeling of myocardium. It is changes in structure of heart, changes in structure of big vessels and small vessels that lead worsening hypertension and can lead to other organ damaging. Next, it is coronary artery disease. Hypertension, it is of the key risk factors for atherosclerosis progressing and, like a result, coronary artery disease. It can be stroke for the same reason. It is aortic aneurysm, peripheral artery disease due to atherosclerosis too, chronic kidney disease, chronic heart failure, and it can be hypertensive retinopathy. It is target organs and target damaging of hypertension. What can we ask in a medical history of patient? The known duration of hypertension and previously recorded levels. Yes, if it was hypertension previously, if it was diagnosis, in what time, in what conditions it was diagnosed, what levels of blood pressure, is it treated or not treated, how successfully was those treatment, and what the present worsening one patient come here now. Any history of symptoms of coronary artery disease and heart failure, like one of the most important pathogenetic factors in hypertensive patients, their presence very severely worsening prognosis for the patient. Other relevant coexisting disorders like a stroke, renal dysfunction, peripheral arterial disease, dyslipidemia, diabetes, gout. Family history of any of these disorders. Social history includes exercise levels and use of tobacco, alcohol, and stimulant drugs, prescribed and illicit. We always ask in history of hypertensive patient about dietary history, focuses of intake salt and stimulants like tea, coffee, caffeine-containing sodas, energy drinks. It is lifestyle factors very important component in medical history of hypertension and current and previous medication, as for hypertension as for all other disorders that use this patient. During physical examination, first of all, of course, we check patient height, weight, and waist circumference. Fundoscopic examination for retinopathy, auscultation for bruits in the neck and abdomen. The unilateral renal artery bruit may be had in slim patients with renal vascular hypertension. We check full cardiac, respiratory, and neurological examination. All that we discuss with general inspection, palpation, percussion, auscultation, all methodics for cardiac system, for respiratory system, and neurological examination. Heart auscultation. What can we find here? First of all, it is fourth heart sounds. You remember previous lecture. In normal, it is two heart sounds. Fourth heart sound, one of the earliest signs of hypertensive heart disease. In starting of remodeling of myocardium, we can hear a fourth heart sound. The abdomen palpation for kidney enlargement and abdominal masses. Peripheral arterial pulses investigation. Diminished or delayed femoral pulses suggest aortic coarctation, particularly in patients less than 30 in young patients. Okay, what is hypertensive crisis? It is emergency of hypertension, the most severe case of it. It is severely elevated blood pressure equal to or greater than systolic 180 or diastolic 110 is referred as hypertensive crisis. Hypertensive crisis is categorized as hypertensive urgency according to the presence or absence of organ damage. The most affected organs include brain, kidney, heart, aorta, and lungs. Yet the same target organ for chronic patients are the same for acute emergency hypertensive crisis. For diagnosis of hypertension, on the first place on diagnosis, it is multiple measurements of blood pressure to confirm. Additionally to it, it can be urinalysis and urialbumin with checking of creatinine ratio and GFR, glomerular filtration rate. Yes, we check function of kidney like a target organ for hypertension. We usually do blood tests. Here we interested in fasting lipids, hematocrit, creatinine, serum potassium, creatinine, or the corresponding estimated GFR, we talk about it, calcium, lipid profile, glucose. We usually do renal ultrasonography if creatinine increased. Evaluate for aldosteronism if potassium decreased. We usually do ACG. If left ventricular hypertrophy, we consider it with echocardiography. Sometimes measurement of thyroid stimulating hormone, T3, T4 hormones, and cortisol to exclude endocrine secondary hypertension. Evaluating for pheochromocytoma or sleep disorders if BP elevation sudden and labile or severe. Okay, checking of blood pressure. Here, not everything such as simple. It can be several types of checking. First, the most usable, the most often, it is office blood pressure monitoring. The patient should be seated comfortably with the back supported in the upper arm bared without constrictive clothing. The legs should not be crossed. The arm should be supported at the level of heart, and the bladder of blood pressure cuff should encircle at least 80% of the arm circumference. The blood pressure measuring device should be deflated at the rate of 2 to 3 millimeters per second, and the first and last audible sounds should be taken as a systolic and diastolic pressure respectively. Neither the patient nor the observer should talk during measurement. Measurements may be both while seated and after standing to look for orthostatic or postural hypotension. At least the first measurement should be done on right and left arms. Here you see how it looks like office blood pressure monitoring taken in the doctor's office by the equipment with all conditions that I said you previously. Yes, and we usually do, if you see this patient first time, do right and left arm to check is it significant difference between them. If it no significant difference, you can check in one arm in further investigation of this patient. After it, you do it in position at the chair, and after it in standing position to check in orthostatic hypotension. And if you need it, you can do a series of measurements with several measurements in several minutes. And we can do ambulatory blood pressure monitoring. It is not always informative for us office monitoring, office checking of blood pressure, because further we will discuss it. Some patients have such problem like white coat hypertension. when they noted hypertension just in office of doctor and in home during their usual activity during day, it is no episodes of hypertension at all. To check it and get more information about hypertension in this patient, we can use ambulatory blood pressure monitoring. The National Institute of Health and Clinical Excellence guidelines recommend that a diagnosis of primary hypertension should be confirmed within 24-hour ambulatory blood pressure monitoring or home blood pressure monitoring rather by relying solely in office blood pressure measurements. 24-hour ambulatory blood pressure monitoring is indicated to rule out white coat hypertension, to uncover apparent drug resistance, office resistance, to better define resistant hypertension, to identify hypotensive symptoms while the patient is being treated with antihypertensive medications, to monitor episodic hypertension, and to identify the autonomic dysfunction states. 24-hour ambulatory blood pressure monitoring also helps identify abnormal patterns in blood pressure that could remain undetected if patient is evaluated based on physician office blood pressure measurements alone. Ambulatory blood pressure monitoring. Yes, it is a daily scheme of result of some patient. You understand that blood pressure during 24 hours will be not flattened in one level. During day it can be lower, higher, even in several minutes according to activity, eating, speaking, doing some exercises, maybe some emotional stress, maybe some kind of walking, some kind of medications, activities, and a huge number of another factors. It can arise or it can decrease rapidly. And you see that we can check middle ranges, but during day it all the time rise down, rise down, rise down. And for us, very important moment to check, because middle blood pressure during night, during sleeping, must be lower than middle blood pressure during day. The extent of nighttime blood pressure attenuation has been mainly quantified through the so-called sleep time relative blood pressure decline. It's what I told, which is defined as a % decrease in mean blood pressure during nighttime sleep relatively to mean blood pressure during daytime activity. More recently, the classification has been extended by dividing individuals into 4 groups. It is, one more time, relation between middle day and middle night blood pressure. First type, it is extreme deepers, when sleep time related blood pressure decline more than 20%. Another type, it is deepers. It is normal variant, when sleep time relative blood pressure declined more than 10% but less than 20%. Non-deepers, sleep time relative blood pressure decline less than 10%. And inverse deepers or risers, it when the sleep time relative pressure decline 0% or non-decline at all, indicating a sleep blood pressure more awakened blood pressure mean. And here you see schemes of systolic and diastolic blood pressure. 24-hour systolic blood pressure pattern, dashed thick lines you see here, of a normotensive deeper subject, left picture, and hypertensive extreme deeper patient, it is right picture, plotted with respect to circadian time specific tolerance limits. It is continuous thin line. You see the level of blood pressure, systolic blood pressure for patient on first picture with normotensive deeper, it is normal, and hypertensive extreme deeper patient, it is hypertensive patient with abnormal nervous regulation, and we see extreme decreasing of blood pressure in nighttime. Here, 24-hour systolic blood pressure pattern for hypertensive non-deeper in left picture. You see that it is no enough decreasement of night blood pressure, systolic night blood pressure, and hypertensive razor patient in right picture. When it is non-changes or when it cannot change or even increase blood pressure during night. The home blood pressure is a better predictor of cardiovascular morbidity and mortality than an office blood pressure measurements. Hypertension is defined as a mean home blood pressure of more than 135 to 85 millimeters Hg. Home blood pressure monitoring provides an inexpensive alternative to 24-hour ambulatory blood pressure monitoring, which is not yet widely available. One of the main drawbacks in home blood pressure measurement when compared to 24-hour ambulatory monitoring is that sleep time blood pressure can't be recorded at home by patient individually, and therefore those patients with abnormal dipping pattern in blood pressure and nocturnal hypertension will be missed. Next sign that we need for hypertensive patient, very important sign, it is ankle brachial index. We can check blood pressure not just at arm, it is typical measurements, but not just one available. We can check blood pressure at leg. And what is ankle brachial pressure index, or ABPI, or ankle brachial index, ABI? It is a ratio of the blood pressure in lower legs to blood pressure in the arms. Compared to the arm, lower blood pressure in the leg is an indication of blocked arteries or peripheral artery disease or secondary arterial hypertension, here specifically for aortic coarctation narrowing, anatomical narrowing of aorta. And how to interpret result of ankle brachial index. Yes, if ABPI above the 1.2, this relation from leg from leg to arm, it is abnormal vessel abnormal vessel hardening from pulmonary venous disease. From 1 to 1.2 it is normal range. From 0.9 to 1 it is acceptable. From 0.8 to 0.9 is index typical for some arterial disease. From 0.5 to 0.8 it is moderate arterial disease, and if ankle brachial index under than 0.5, it says you about severe arterial disease. And what to do with it, what your further management if you find one of these situations. And here you see a very simple but useful scheme how to interpret result of office blood pressure or clinic pressure. Is it lower than 140/90 or higher? And mean 24-hour ambulatory blood pressure, mean blood pressure during all 24 hours. And here we take normal 430/80, if it's lower or is it higher. And how to interpret if both of them normal, it is true normotension. If both of them increased, it is sustained hypertension. Yes, here is all simply. If clinic pressure is increased but we have normal numbers of ambulatory blood pressure monitoring, it says you about white coat hypertension. And if you see elevation just mean 24-hour ambulatory monitoring, but in office it was all okay, during measurements it was normal blood pressure, it says you about mask hypertension. It is hypertensive patient too, but we didn't take the results in office blood pressure. For some reason there was normal in those moments. Yes, and here we include a picture that maybe it is a sign, it is a time to change color and model of code. You know that a lot of medical coats and a lot of medical suit for today available in different colors, and really in clinical practice some patients take it more easy when you are in some new and some another form of medical suits. A little bit more about white coat hypertension. White coat hypertension, more commonly known as white coat syndrome, is a phenomenon in which patients exhibit a blood pressure level above the normal range in a clinical setting, though they don't exhibit in other settings. It is believed that phenomenon is due to anxiety and those sites experienced during a clinical visit. The term masked hypertension describes the contrasting to the white coat hypertension phenomenon. And what we see here, yes, let's discuss a little bit main target organs and damage by hypertension. And one of the most dangerous, it is eye. Here we can see hypertensive retinopathy, and at this slide I want to show you the grade by Kate Wegener-Barker of hypertensive retinopathy. In general, hypertensive retinopathy it is a damage to the retina and retinal circulation due to high blood pressure. Grades of it. First grade, it is arterial constriction, attenuation, sclerosis, silver wiring, and vascular tortuosites. And you see here the picture with the hypertensive retinopathy. It is changes of retina in severely hypertensive patient. And what we can see in these pictures, it is peripapillary and periarteriolar retinal changes, including cotton wool spot. You can see on second, third picture like white spots. It is retinal hemorrhages. It is from red to blue spots in these pictures. It is local hemorrhages, and it can be exudates on the first picture. Second grade. It is a grade 1 plus grade 1 symptoms, previous symptoms plus. It is irregularly located tight constrictions known as AV Nikin or AV nipping. Next grade, it is previous grade plus retinal edema, cotton wool spots like in these pictures, and flame hemorrhages. It is hemorrhages that look like a flames. Fourth grade, it is symptoms of grade 3, and additionally to it, it can be present swelling of optic disc or papillary edema and macular star. It is hemorrhages through the macular capillaries, like they look like a star. You can check it due to during ophthalmoscopy. Here you see Here you see a device for this investigation. Usually it done by ophthalmologist, but it is a usual skill for general practitioner. That's why we usually have to know how to do it. We have to know technique and normal anatomy. Here you see picture of normal fundus. It is looking of normal retina, its anatomy, its compounds. You have to know, because let's return. When you see this picture, you have to understand what signs are abnormal, what signs are responsive for what disease. And like here, for example, you see that it is absolutely different picture from this one, and it says you about hypertensive retinopathy. Next target organ, it is kidney. And here how we check it, it is visualization usually. Additionally to lab test, it is for creatinine, radio and GFR. We do renal sonography. We can check here the size of the left kidney, that is small, like in this picture, 137 centimeters in length. It is quite small. And echogenicity of the kidney in increased and patient with left renal artery stenosis. What else we can do? If we suspect renal artery stenosis like a cause of secondary hypertension, we can do a combined renal artery Doppler ultrasound and arteriography. Here you see the pictures of results of this investigation, and you see visualization of renal arteries. And in second picture you see like with the right color arrow, place of obstruction, place of significant narrowing of renal artery that exactly can lead to hypertension. And we can check it one more time with renal color duplex sonography. Here we see normal appearance of the right renal artery, right accessory renal artery, single left renal artery by arrows, and abdominal aorta or longitudinal view of color flow image. Here on renal color duplex sonography too, you see in different colors remarkably turbulent. Yes, it's not, you see blue coloration. It says you that blood flow goes not just in one way. It has some returning and some turbulent flows in this place. And on Doppler it looked like this. It is remarkably turbulent flow at the stenosis of the right proximal renal artery on longitudinal view of color flow image. Here it is spectra Doppler 2 that show us high peak systolic velocity at the right renal artery with hemodynamically significant stenosis. Additionally to it, more rare, but we can use renal magnetic resonance imaging. Usually in most patients it's enough ultrasound with Doppler, but sometimes we need MRI to detailize some structures and to confirm some moments. Even more rare than MRI, we can use in some very rare cases, but it's possible, renal radionuclide imaging. Imaging of kidneys involves IV injection of technetium or mercaptoacetyl triglycerine and lying on table for hour or more while imaged by gamma camera. Yes, you see pictures with visualization of kidney, and it will be some detailizing, and it will be all blood flow, all vascular structure, and it will be visualization of kidney tissue. Next target organ, it is brain. Yes, it can be some central nervous system problems. And what is the danger? First, it is less severe venous transit ischemic attack or a more severe stroke. It is two acute types of brain damage, and chronic type, it is chronic hypertensive encephalopathy. Here you see example of MRI imaging for brain. It is the most informative instrumental technique. For brain, we are always optimal to use MRI. And here you see brain microbleeds in arterial hypertension patient. Yes, in peak of hypertensive crisis, this patient undergoes small bleeds in the brain. Here they are seen like a small, homogeneous, round foci and low signal intensity. You can see there by rows on the pictures. Okay, usually we do a chest x-ray for all patients with hypertension. Because it is a simple and quick and not expensive way to check structure and size of heart and big vessels. And here you see example of simple routine chest x-ray in hypertensive patient, and here we can see such a big size of heart. It will be definite left ventricle enlargement. You see that it is significant enlargement, primarily due to enlargement of left ventricle. And left ventricle hypertension, it is a very often result, very often complication. It is hypertrophy and remodeling of left ventricle, because heart and myocardium, it is one of the target organ for hypertension. Okay, let's return. I include renal ultrasonography. Indications for it: if urinalysis detects albuminuria or proteinuria, cylindruria, microhematuria, or if serum creatinine is elevated more than 1.4 in milligrams per deciliter or 124 in millimoles in men, and for women it 1.2 and 106. Renal ultrasonography is indicated to evaluate kidney size, may provide. Okay, by slides, that's all. What about hypertension? Today I include for you the main moments, just the interesting picture. I decide not to include a lot of information because hypertension, it is a very huge topic. But what connected exactly with hypertension? It's just levels of blood pressure. It is typical symptoms due to high blood pressure. Clinical manifestation, we discussed them. It is classification by level of blood pressure, classification by organ damage, classification by risk score. I showed you this classification, and learning it home one more time. And all another huge information about hypertension is connected with complication. One more time, it is target organ, it is central nervous system and exactly brain. It is heart, myocardium and vessels. It is peripheral arteries, like peripheral arterial disease, and it is kidneys, and it is retina. It is most danger and prognostically the most important organs for hypertensive patient. That's why please at home read and learn evaluation all of these systems, all of these target organs. Repeat please neurological evaluation of patient, because most hypertensive patient will have problem with their neurological status. And for today that's all. I wish you good luck in your learning, in your education. If you have some questions, some comments, maybe some discussion about hypertension, I'm waiting for you in comments under YouTube video, or in our closed Facebook group of our department. This video will be there too. As usual, I ask you to leave your name and your group number under this video in comments. And for today, that's all. Goodbye.